Come on, full. Okay, I think we're recording. Did it say record? Did you see me say yes? I didn't see me say yes. It's recording. Okay, there's my voice. See the little green line? So, Eric, you're going to hear me this time because the voice is going on the green. I'm working on this. All right. Okay, let's talk about Brian. Brian is a really cool guy. He's 22 years old, and he lives in a small mountain town in Colorado. He is highly allergic to dust, pollen, anxiety appears to play a role in exacerbating his asthma attacks. Brian's wife, man, he got married young, drove him to the clinic when his wheezing, and he was unresponsive to fluticasone and ipratropium bromide, which is Flovent and Atrovent inhalers. He was unable to lie down. He began using his accessory muscles to breathe. On arrival, vital signs were 152/84, heart rate 124, respiration rate 42, 38 temp, and he was started on 4 liters nasal cannula. An IV of D5W at KVO was done, and he got these blood gases. His pH is 7.31, CO2 48, bicarb 26, PO2 55, and his SATs are 88. So let's interpret his gases. First of all, his pH is, he's acidotic. And his CO2, so that makes him acidotic as well. And his bicarb is normal. So now what would you say that is? Is it compensated or uncompensated? Uncompensated. And tell me the difference between compensated and uncompensated. Yes. So what we look at is that pH normalizing. So the closer it gets to the normal range, compensation is happening. That's the easiest way to remember it, I believe. Yes. And then it's uncompensated or partial. If you're going to get down to that, and let me honestly tell you, I'm never going to test you on partially compensated. We're just going to say it's either compensated or uncompensated. And that's going to happen in the hospital very rarely. You know what you're going to see is that you're going to see a bunch of nurses and respiratory therapists standing around going, well, it's partially uncompensated. You know, big whip, let's fix this. You know, like that's really what you're going to see. So is it compensated or not, acidotic or not, respiratory or metabolic, okay? So this guy is an uncompensated respiratory acidosis, this young man. So let's talk about the, let's move on where it's, oh, you fun thing. There we go. So the underlying pathophys of asthma, it is a complex chronic inflammatory disease of the airways. How many people in this room have asthma? How many people in this room have had asthma diagnosed since a child? You had it as a child and you have outgrown it? It hasn't reared its head again yet? Yet? Okay. Anybody else have it as a child? When did yours first develop? How old were you? Oh, isn't that a nice little surprise for you? Yeah. Anybody else? Okay. Well, which is kind of occurring right now. We've all heard your coughing. That's okay. So it's characterized by a variable and reoccurring symptoms due to a combination of underlying inflammation, bronchial hyperresponsiveness, and airflow issues. And that's according to the National Institute of Health, the NAEPP. So it's can also be caused, be referred to as an autoimmune disease because they don't really understand why there's this hyper responsiveness to an allergen, typically. So it results in inflammation and widespread narrowing of the disease, of the airways, pardon me. So first of all, we're going to see an immunological response, and we see an activated immunologic response. It stimulates the IgE, first of all. And then we will also see an increased airway resistance, and we see a lot more mucus filling up the airway, so that inhibits the flow of air, so we have big mucus production going on. And then we have a decrease in lung compliance. Because that swelling of the tissue of the lungs, it makes it more difficult for the lungs to expand with inspiration. And a lot of times people who have asthma or lung issues, they feel like they're not getting enough air rather than being able to exhale. It's air hunger kind of thing. And then we have the impaired mucociliary function. So all that cilia that sits in our lungs and does that lovely little, ooh, let's move the mucus along, gets this pluggy old tenacious fluid, and the cilia is like, right? So it's junked. And then because all this mucus is in there, we have narrow airways. Oxygen is having a hard time getting down to the to exchange. So then we end up with altered gas exchange because of it. So that's the whole little combo of asthma. Make sense? I'll put this up. I put them up last week, didn't I? All right. Did I send them to you too? Okay. Making sure I do. All right. So Brian, are his vital signs acceptable? Okay, he got a little older, but he's still 22. But he's still Caucasian. Okay, so let's talk about his vital signs. Heart rate's too high. Blood pressure is high. Respiratory rate, pretty high, pretty high. Okay, so he has a high blood pressure. He's tachycardic, and he is working very hard to breathe. Therefore, he's increasing his metabolic rate. Therefore, you see the temp goes up, and because I wrote it there too. So good for reading that writing. And increased stress. So it's going to get worse. Those of you who have had an asthma attack, it ain't fun. It's pretty scary. So you're pretty stressed. You can't breathe. So these people are posturing. So when they come in, do not lay them flat on a gurney. They will punch you in the throat. Right? Nursing measures. High Fowlers. And O2. Okay, so let's talk about his, oh shoot, I just gave you the answer. His O2 SATs are what? Is that acceptable? Is it acceptable in Colorado? Still not acceptable in Colorado, but it should be greater than 90. Like if it was 90 here at sea level, we'd be pretty excited about that, right? We'd be like, oh, this patient's sick, his SAT's only 90. In Colorado, you're like, awesome, it's 90. Okay, so it's different. It's gonna be different. Yeah, you adjust, you compensate. You compensate. And yeah, it's harder to breathe in the mountains. It's not just the hiking or being out of shape. Yeah, you have increased RBC production because your body's like, oh, I need more oxygen. I got to get this bus production. We got to get that hemoglobin out there to grab some O2, right? That's what's happening. Okay, so yes, so there he is in Colorado. So that's before his asthma attack. So what drug classifications and actions of fluticasone and ipratropium bromide? Anybody want to take a stab at that? Well, fluticasone, first of all, what's that? It's an inhaled steroid, and what do steroids do? Decrease inflammation of the airways. Therefore, we're going to decrease swelling, decrease mucus production, and decrease the spasm of the airways, which is happening. It also decreases the airways sensitivity to irritants and allergens. There's very few systemic effects to inhaled steroids, which is why we prefer them over oral, but we will still do oral steroids for a big fix, right? This drug is a regular dose drug. It's to be used regularly, dosed regularly. It's not a rescue inhaler, okay? It's a regular drug. It's a maintenance. So it's an anticholinergic. Ipratropium bromide is an anticholinergic. Fluticasone is a steroid, and so what it does is it relaxes the Atrovent relaxes the smooth muscle, so we have more dilation. So you can understand why they're using both of these together, right? It's making sense. However, this is not a fast-acting inhaler either. So for someone who is in crisis, in a respiratory crisis, asthmatic, respiratory issues, we don't like to diagnose people with asthma as much as they should be, but we talk about reactive airway disease, we talk about bronchitis, chronic bronchitis. Chronic bronchitis 3 years in a row is what? It is COPD. They haven't diagnosed you with that, have they? Okay. Is asthma COPD? It's in the umbrella. It's part of it. But us asthmatics, we really don't want to be COPDers, but we are. COPD is chronic obstructive pulmonary disease. Is asthma chronic obstructive pulmonary disease? Yeah, somewhat. It's also sort of flirts into that autoimmune stuff, because there's that trifecta of, I can't remember, maybe Maria remembers this one. Eczema, asthma, and allergies. It's a three, what is that? Is there a name for that? It's just a common occurrence. Individuals who have eczema, asthma, and allergies often, what is it? Atopic. The triad is atopia. Yeah, well, it's not utopia by any means, it's atopia. So those people who have all three of those diagnoses typically, have lifelong asthma or have lifelong respiratory issues and chronic issues. So what else does the body do to, let's just talk about asthma for a minute. What else does the body do to compensate for someone who has asthma? Increase the size of the lungs, actually end up increasing. They get big, big lungs. Their diaphragm flattens out. The body's trying to compensate by getting bigger, right? Oh, if I get bigger, can I pick on you? Can you come up here? I just want to show you, because can you take your jacket off for a minute? Yeah, we can do it back here if you want to do it back here. Oh, we'll do it back here. Okay, so I guess you and me were standing next to each other.
Okay.
Respiratory girls. Okay, so let's look at this lovely specimen. Okay, so her lateral measurement, her lateral across here, from here to here. May I touch you? Sure. Okay, right here. Put your arms out like this. Okay, now step away from me. Okay, now if I want to look at her AP measurement, turn sideways and come back into that. Okay, it should be half, right? Half. You get to do me now.
Okay.
Okay?
Okay, step away.
Okay, step away. Okay, pretty wide. Oops.
And back in.
Pretty much the same. Look at. Pretty much the same. This is called a barrel chest. Because my body, over the years, has compensated, thank you, for showing off your normal chest. And so we're just talking about rib cage here. We're not talking about breast size. So I have a barrel chest, okay? So my body, over the years, has compensated to try and increase my oxygenation because I've been an asthmatic since infancy. Yeah, I got great stories. Anyway, so that's another crow. You can. How many crows did you guys see today? You need to go in for sleep apnea. Did you?
He was like, I don't sleep. I started asking him questions and they were all heavy.
Crow. Those crows. And you saw one? Or you see it all the time?
I look all the time now and I see them everywhere.
They're everywhere. So this is part of your assessment. Watch for your crows. There was one that was out here while you guys were walking in, just walking around. How many people saw him? Yeah, nobody's going to admit to that. Okay, back to the drugs. I took a little holiday on that, didn't I? Okay, so now, fluticasone and iprapropium bromide, are they appropriate for use during an asthma attack? No, I already said that. They are not fast acting. So asthmatics need to have their rescue medication on hand, which is typically albuterol, also known as ProAir, also known as Ventolin, also known as what? I don't know. I can't think of any other ones. Does anybody else know any other? QVAR? Is that a mix or is that the same? Might be a mix. I don't know. Anyways, albuterol. Generic name's albuterol. That's pretty much our fast acting. And they need a peak flow meter and they need to have a plan. Asthmatics need a plan because things can turn badly pretty quickly. So the step approach that we have to managing asthma in adults and children are basically they add as they go up. So first you have intermittent asthma, you get albuterol, PRN. Then they may add a low-dose corticosteroid with it. So they may add in fluticasone, okay, albuterol and fluticasone. So maybe you're going to start taking fluticasone twice a day. And then the albuterol is there for. They may also put in an oral medication. Theophylline is probably one of our oldest ones. I don't see it used very often anymore, but it's probably still on NCLEX. So I haven't seen theophylline used in forever. It's probably still there though. If they're still listing it on this stuff, there's probably still a reason for it. Leukotriene receptor agonist. Leukotriene inhibitors such as Singulair. I am the poster child for Singulair. I tell you, my life changed when that drug came on the market. From going from being an allergy, wheezing, itchy individual, that worked for me. So it blocked that inappropriate immune response I was having. So that's been added to it. Step 3, they're going to keep adding to step 5. And I looked this up last night. This is I looked it up last night, now it's not out of my head. Somebody tell me quick what it is. It's a monoclonic, yeah. Anyways, they're using it now for individuals who have allergies, who are non-reactive to our traditional modes. Anyways, I can't remember. I looked it up and went to bed. Okay, so this physician orders albuterol 2.5 milligrams, iprapropium 250 through nebulizer, and what's the rationale for that order? Anybody want to say why? So it's a big, so we have a bronchodilator and we have an anticholinergic, right? So we're using both of those methods. So we're trying vasodilation for both of them. Ipratropium. This is both, these are both through breathing treatments. Well, you know what? There was a study, yeah, I believe that doing a nebulized treatment is faster acting because when you think about somebody sitting there for about 5 to 7 minutes breathing in this nebulized medication back and forth, right? Versus using an inhaler where even with a narrow chamber, maybe 2-3 breaths, right? I think it is, to me it makes sense. However, there was a study done that there is no difference between the two. However, if you look at who funded the study, I'd like to see the study redone. Totally different. Nebulizer and their inhalers. I think part of it also has to do with the actual action of sitting there, calming yourself, breathing, doing the nebulization, because an asthma, someone who is in a full-blown exacerbation, it's really scary and stressful. So they're cranked up. So I really think part of that whole experience helps them relax, not only respiratory-wise, but psychologically as well. Because there's a huge factor, a psychological factor, which is why we as nurses always come in very controlled, in control, even though in your head you're like, oh my God, this is bad. It's not. You're going to have them breathe with you. You're going to decelerate the issues. Okay, so rationale for immediately putting oxygen on him. Okay, well, if somebody has a crappy saturation, we're going to give them oxygen, right? When would we ever withhold it? We never withhold it. We never withhold oxygen. We'd be very cautious with someone with COPD, depending where they are in the, what kind of state they're in, because if they're truly in respiratory distress, we're going to give them more. Okay, so what are the, oh, that is not listing it. Okay, the next question is 5 short-term interventions that will help relieve his symptoms. So he comes in. We know what his vital signs are. We know he's breathing at 42 breaths a minute. What can we do to help him? We did not lie him flat on the gurney. What else? Put him in high fowlers. Okay. Tripod position. What's tripod? Leaning forward. What does tripod do for you? It increases your lung expansion ability, yes. That's why people who were runners always put their hands on their knees when they're done running, right? What else can we do for this guy? How about loosen his clothing, loosen things up. Be calm yourself, elevate the head of the bed, put oxygen on him. We're going to hydrate this guy. We're going to give him a short-acting SABA, probably nebulized because we think that's best. We believe it is. The physician will probably believe that else as well. And is there anything you can do, else you can do with these individuals? Treat their anxiety how? Don't leave them alone. Breathe with them. You know, I often will come up to them and I'm going to pick on you now, Mega. So I'm going to make eye contact and I'm going to lean in forward and tripod with them and I'm going to say, let's breathe together. Breathe with me. In through your nose. like you're blowing out your birthday candles when you exhale. I'm going to teach them pursed lip breathing. What else am I going to teach them? Diaphragmatic breathing. How am I going to teach them about diaphragmatic breathing? How do they know? A hand under your stomach and a hand on your chest. This is my lovely gut demo. It's opposite, right? When you belly breathe, this hand goes in, that hand goes out, right? Let's see. I look at how I expose myself for you guys. Barrel chest, big belly, you got to see it all today. So we're going to teach them belly breathing. We're going to teach them pursed lip breathing. We're going to teach them how to, I always say, find their zen, but we're going to talk in a very calm and reassuring way. We're going to talk about being with them. I'm not going to leave you. Somebody's here. Somebody will always be here. I'm going to be with you. Okay, so we're going to talk them down. Right. Happy place, guided imagery, that really helps. Now, this is not a joke. I'm just going to relate my asthma adventures over the last 57 years. When I would lie in bed at night and would hear that, my wheezing, the whistling, boy, this really is going to tell you how old I am. They used to, when I was a small child, so this is in the 60s, they used to read the comics, the Sunday comics on the radio. God, that sounds so old. But in my mind, that sounded like the comic characters. So I would just pretend that I was looking at comics and those were the characters talking. And that would kind of help me relax. So it was guided imagery I didn't even know I was doing. So you can help your patients by sending them somewhere that they like, because it's not very comfortable to be where you can't breathe. Does that work for your kids? Yeah? Yeah. Yeah. Sit in the shower and sing, and they breathe, and you get the mist in there, and there's some humidification happening, and then they start to cough out that yuck. Okay. Yes, we do introduce mucolytics. In fact, yes. So you're thinking of like guaifenesin. Yeah, it's not that quick acting though, right? So if you sit in the shower and sing, it's going to be faster than guaifenesin. Okay, so loosen clothing, quiet environment, saba with cool mist. Oh yeah, that's the other thing. If you're going to humidify, do not heat that. And this is just a patient perspective. Do not have hot air blowing in my face if I can't breathe. Cool is better. Elevate head to bed, oxygen, hydrate, cough effectively. Talk to me about huff coughing. Does anybody know how to huff cough? I guess you better figure out how to huff cough, because you got to be teaching your patients how to all right? Deep huff cough. I'm scared to do that again because something might come out. All right. So after several hours, well, we're talking about sputum. Several hours of IV and PO rehydration and a second albuterol treatment. How often can you give a albuterol treatment? Q2, 2, 4, 6. We've gone here. 4, 2, 6. Depends. It's usually Q4, and then, but you can do them continuously, like they do continuous in a real crisis while you monitor the patient. The patient must be monitored, because what does albuterol do? Increases their heart rate. What's his heart rate right now? So they're freaking out. Probably Q4, Q6-ish, but we do it back to back sometimes. his wheezing and chest tightness resolve, and he's able to expectorate his secretions. The physician discusses Brian's asthma management with him, and the patient says his inhaler meets his needs on a day-to-day basis, but fail him when he has an asthma attack. Oh yeah, we know that. And the physician says we're going to put him on a steroid burst, so 40 milligrams a day for 5 days. So that's just a short burst. Now we are is that appropriate to do it that way? Often we will see a taper. So a taper would be 40 for 5 days, 30 for 5 days, 20 for 5 days, 10 for 5 days, 5 for 5 days. How many days out are we now? Close to 20 or 30 days, right? That's a taper. Why do we do a taper? Rebound effect, because we are masking the body's own steroid production, right? Corticosteroid production, which is where from? Thank you. Thank you. Just to make sure you guys all know that. Okay, so they've chosen to do a steroid burst on him. And for someone in this case, it's appropriate, but a physician may choose to do a taper too. I'm not going to get into the positive and negatives of either. They might do either one. And then they also ordered him an inhaler, 2 puffs Q6, using a spacer, and he should go up with a pulmonologist. So what issues are you going to address with him in his discharge teaching? What do you need to talk to Brian about? Okay, first of all, yeah, triggers. Let's first of all ask his wife to come in too, because it would be helpful for her to know as well. And we would want to know, so we're going to educate him on his medications and his dosage, but we're also going to educate his support system on his medication and dosage. We know he knows that the present inhalers continue to use them on a daily basis, but have the talk to me about MDIs. Oh, maybe I'm going to go into this in a minute, aren't I? You want him to demonstrate how to use an inhaler with you. You want to have him explain back to you the dosages to you, and have a plan for exacerbations. All asthmatics need to have a plan, and then also to keep a journal, a trigger journal, which is what Josh suggested. These are all terrific things. Asthmatics in the room, do you do any of these things? Nope. You only got to step 1? You take a mental note. Yeah, okay. Say when you were first diagnosed, were you a little bit more careful about what you were doing? Oh, okay, so you're still fighting. You're in denial still? Okay, well, forget it. We're not talking to her about this. She's just going to deny it. Oh, you had a black mold reaction. Denial's good. Okay, so being a lifelong asthmatic who knows what her triggers are mentally, I've never kept a journal. I used a peak flow meter. Well, after I almost died, I did do a few of these things, so for about a month, and then I quit. So, oh yeah, I smoked too. Thinking about vaping. No, I'm kidding. Of course I did. Of course I did. All those silly things. Okay, so, and then NSAIDs use. NSAIDs, and this typically you'll see it maybe with older people, but NSAIDs can trigger asthma. So aspirin-based products, so which are the NSAIDs, are aspirin-based. they can cause a reaction. Hmm? Yeah, food additives. Like if you have somebody, okay, I'm going to give you my asthma story just because you need to know it now. So I'm 8 months old, sitting in my high chair, having, doing what little fat 8-month-old kids do. And my mother's cooking freshwater fish she's frying fish for dinner. She turns around and looks at me. I have angioedema. I'm puffed. I'm stridering. I have stridor just from breathing in the smell of the fish cooking. Okay, here's your 8-month-old. You turn around, you're cooking fish, and all of a sudden, right? Pardon me. So, being the wise old RN that she is, she pulls me out of, so this is 1961, right? Pulls me out of my high chair, runs out to the back porch, and puts a bottle in my mouth, because if you keep that airway open, right, that baby is breathing and sucking, and she takes me out of the insult, away from the allergen. She takes me outside into the fresh air. It's probably 40 below. It's probably, we're in Saskatchewan right now. It's probably winter. No, maybe it wasn't winter, but okay, it's cold, probably. Anyway, so she keeps me outside, keeps the airway open. This is the first insult, right? This is the first allergic reaction to fish in the air smell, right? Okay, so she figures, I think my kid's allergic to fish. Hidden things, fish sauce is everywhere. You eat anything Asian food, there's fish sauce in it. So if you have a high allergy to fish, you'd be on the alert for fish sauce. So I think I've done pretty well to survive this long, knowing about my fish allergy, because it's pretty significant. Fast forward a few years, piece of pizza that has shrimp on it. Put it up to my mouth. Okay. Out fishing, putting a fish hook, playing with the fish hook, rubbing my eye. Okay. I have a fish allergy. Huh?
How did you go fishing to get a fish allergy?
I'm a kid. I want to go fishing with everybody. Okay,
Being around the air.
I know. When you're 8 or 9 or 10, you don't think about that stuff, right? I know I'm not supposed to eat fish or walnuts.
Or be by it, or breathe in the smell.
Yeah, we're there. Okay, so fast forward 25 years later, let's say, and I'm at Benihana in Atlanta, Georgia, at a critical care nursing conference. I'm sitting at Benihana with 5 of my best friends from Tri-City ICU. And all of a sudden I'm like, shit. What am I doing? I go outside. I'm tripoding over top of the newspaper stand. The little waiters behind running up, you have to pay, you have to. I'm like, ugh, I can't breathe. My ICU CCRN nurses are in there shoveling their food in. Finally, one of them decides to, well, maybe we should go see if Sue's okay, because she has asthma, right? So Bob comes out and I'm like, ugh, he goes like, so what do you want to do? I'm like, she needs some epi. So, okay, well, let's get a cab. So we hail a cab. I can still see this. We're in Atlanta. Big black driver. He's got his saxophone next to him. I'm sitting in the front with him, posturing, doing all this. Maybe Bob was in the front. No, I think I was in the front because I saw the thing there. And Bob's like, okay, well, we're going to go to CVS or wherever, Rite Aid or whatever, somewhere like that. So we're going to a drugstore. And we go by the emergency room. We sign. And Bob goes, you want to go in there? I'm like, denial, right? And I'm not breathing. And the guy, he's not really pleased about this. Bob jumps out of the car. We get to the drugstore. He runs into the drugstore, throws $10 on the till. What is he going to go get? Benadryl? Is, can you get an EpiPen for $10? Can you get an over-the-counter 10? No, remember there's this, well, that was a few years ago, but. Well, probably would have been smarter to go to a fire station. But what did I go and get? Yes. Actually, I don't think you can go and get it anymore. But up until just recently, you could go and buy, a Primatene mist inhaler. Primatene mist inhaler. You could buy inhalers at the drugstore, and it was epinephrine. Just epi. They've taken it off of the market now because people have died from overdosing themselves on epi. So Bob runs back out to the car, gives me the Primatene mist. I'm like sucking that down. It's working pretty good. We go back to Benihana's. I didn't go back in. Get everybody, get back in the cab, go back to our hotel, go to the bar, have a beer. Just another day in Atlanta. Not very smart. I mean, really, that whole story is out of control. But that is what a typical asthmatic is like. Okay, lifelong asthmatic since 8 months, and I still can't get it together. I've never been to Benihana since.
So you have an EpiPen now?
I carry an EpiPen in my purse.
I think when you got your bag too.
It's in my it's in there. But I do have it, and every EpiPen that you guys have played with down in the lab are my rejects. So as soon as they go expire, they go to the lab. I would. If I didn't have any choice, I would use it. I don't really know a lot about expired drugs. I think they become weaker.
They don't magically expire.
But they don't magically, no, they don't know to expire on a certain date that's printed on their vial. They don't know to do that. It's like food. Yeah, although food does expire. I've had to educate my husband in that one. Anyways, so somebody just left. I want them to make sure they see this next thing. She had to pee quick, okay. Oops. Because this is well worth it. So we need to, what have we talked about? What we can teach our patients. Let's go over that real quick. What can we teach our patients to handle their disease process? Oh, get vaccinated is good. What else? Use a spacer. Pursed lip breathing. Diaphragmatic breathing. Now this transfers into COPD, right? We're talking about respiratory here. What else do we want to talk to them about? If you're an inhaler, rinse your mouth out, because if it's a steroidal inhaler, we're going to invite thrush to come on and visit us, and that's not good, right? Carry your meds with you. Take care of, know your triggers. Keep a journal. Use a peak flow meter. Medical alert? Sure, they could, sure. You can have a medical alert for anything. Yeah. Okay.
Do people have like valid medical alert tattoos or?
Never heard of it.
I've seen people that have them that are diabetics, but I don't know if it works. It would work the same.
Talk about the DNR tattoo.
Oh, well, that's a joke. A nurse always talks about having that, but I don't know.
I would say like a nursing judgment, they'd be like, I think this person is have that, but
I don't think it's illegal. At least when I did my EMT class, they were saying that if someone has a tattoo, like it's not, like technically it's not.
Okay, that's what I was going to ask, was what EMTs, how would they react to it?
If it's like a DNR, they have to have.
It has to be written and, okay.
They can't send the paperwork.
well, not DNR. I just mean about like if someone had like a
I don't think it's legal. I don't think that's.
You have to get a medical bracelet.
Yeah, you have to get your medical alert bracelet. Has to be done in an official way where tattoos do not. That might be. I don't honestly don't know, but I want to show you this because the lesson that we learned from this is fantastic.
My asthma. They said they'd fix it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes, and you need to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
Joke.
Okay. So, do I look like an idiot? Make sure you have your patients demonstrate to you how they use their medication and medication delivery devices. There's some respiratory inhalers that involve a capsule that you put in that has to be punctured, and you have to flick the thing and inhale the powder that comes out of the capsule. So, as much as you as new nurses want to do that for them, the first thing you do is hand it to your patient. Say, show me how you use this. Because you need to assess whether or not they know how to use it. So that must be done. So Dr. House assessed. And what she had in her hand, that was a Primatene inhaler, by the way. The way it looks, I know exactly what that is. I've had to use those a few times in my life. So that was a Primatene inhaler. So up to that date, you could still buy it over the counter wherever they filmed that. So let's move onward. So you ask him to demonstrate his metered dose inhaler, and he vigorously shakes the canister and holds the aerosolizer at an angle pointing towards his cheek and squeezes the canister as he takes a quick deep breath. So probably not effective. So no space, fast inhalation, like they say in Iggy, you're supposed to be about an inch away. Or if you're using the aero chamber, it's hard to get, well, depends. Kids use aero chambers really well. They also come with a mask type that can be fitted over their face. Kids that grow up on aero chambers will continue to use them. You introduce an aero chamber to grandpa who watches his grandson use an aero chamber. He's going to say, I don't use any of that. That's for kids. That's what my dad said. My dad wouldn't use one because it's for kids. So, therefore, they have poor coordination angling towards their cheek. He had no breath hold. He didn't rinse his mouth. We talked about that. And it's important to clean your inhaler because the pinhole that mist comes out, it crystallizes in there. So pull the canister out of them, show them how to pull the canister out and put it under a forceful stream of water, and that will blow out the hole, and then you put it back in, and then the medications works fine. I have an older brother who has COPD who just learned that because I couldn't stand watching him suck on that thing over and over again, and I thought, oh my God, he's not getting any medication out of that. Nobody had ever taught him to rinse out his canister. So you need to make sure you teach them to do that. And they just need to be under soap and water. You don't need to boil any of this stuff or mini nebs either. Don't boil that equipment because it'll melt. I know that. I've done it. Yes. You need a prescription to get the medication put in nebulizers, but you don't need a prescription to own a nebulizer. Is that what you're asking? No, I think probably everybody who's ever had a reactive airway disease diagnosed on their kid has a nebulizer in their closet. So what are we going to teach him about his use is we're going to use a spacer or open mouth and hold his breath for 10 seconds. Now, if he's taking both of those medications, how should he take them? take the bronchodilator first and wait a few minutes and then take the second medication. So it gets deeper, is the rationale. His wife asked the possibility of Brian having another attack. How do you respond to that? Well, yes, he most likely will. So the triggers, even if they're in your head or in your diary, the goal of asthma is to manage the disease. You need to get a pulmonologist. Peak flow meter. A peak flow meter is a predictive. It's a little device. There's one down in the lab, and Denise will show it to you if you're interested. It helps patients understand where they are in their restrictive airway. So the peak flow meter, I think I go into it a little bit more. Here we go. It measures the maximum flow rate that can be generated when an individual takes a maximum inspiration, expels the volume, and a maximum expiratory effort through this device. So then what it does is it says, okay, you're in the green zone. Green is good. Yellow zone is like, oh, you have some restriction. And red zone is you're in trouble. So it helps the individual along in their journal. They can keep trend. The idea is the trending. So if you start to see that you're trending towards yellow, maybe you've got a cold or you're getting sick, something like that. It's to help you be prepared rather to get into a full-on exacerbation.
I guess the calorie count happens fast, but it usually progresses slowly. It usually if someone's having an asthma attack, they were totally fine in the green zone and then.
Well, it can be both. Okay, so maybe you have asthma and you get a cold and you're slowly decompensating. That's a slow progression. Your asthma's flaring slowly. You run into shrimp, or you run into Benihana and it's cooking. Your asthma progresses very quickly, but actually you're having anaphylaxis, right? But it is connected because it's all part of that whole triad of hell. Sorry. What did you call it again? Atopia. Not utopic, it's atopic. Okay, so here's that peak flow meter and the precise instructions. There is a test question on ordering this. I'm not going to give it to you. It's stupid. I think that's a stupid question. What order do you do things in? But the idea of that question is to know how to teach the patient how to do it. Okay, so you do need to know how to use a peak flow meter when you're teaching an asthmatic. And also, get them, okay, so here's another story. The aero chamber. My son had asthma, or he still does. And I would leave to go to work, and the babysitter, I'd give all these written instructions on how to give him his aero chamber and blah, 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 blah. I came home, and the inhaler's in the aero chamber with the cap on it. So he probably got his doses. She was probably really good about giving his doses, but the cap was on. So he didn't get any medication, right? So make sure as ridiculous as it sounds, you've got to tell them, take the cap off, put it in like this, You have to explain everything. And it's not because they're stupid. They just are not aware of how to do these things. Their life isn't surrounded in nursing and medicine. They just don't know. Okay, and so during the follow-up visit, Brian's asthma is listed mild persistent. His peak flow on the albuterol and, I spelled that wrong, trimicolone, has been 450 liters per minute, which is 88% of predicted. His cough has subsided. He can again participate in sports without problems. There's no nighttime wakening, no loss of work, no emergency department visit. He demonstrates appropriate inhaler technique. Peak flow record is available. Boy, he's a good boy. He knows that his MDI is empty when the canister floats on its side. That's the other thing you want to teach them, is how do you know when your canister's empty. Now they have like a little number on the back, and it decreases as the inhalations are gone. But I have discovered you can get probably 10 to 15 more out of it. So people are going to use those past when the number goes down. So you pull the canister out, put it in water, and if it's floating on its side, it's empty. Okay? If it's floating up and down, there's still medication in it. Goes on its side, no medication. And he's noted that the wood smoke in the air causes him to cough. Like, remember, he lives in Colorado. You know, they're all woodsy there. And he pre-treats himself with albuterol when exercising outdoors in the winter. Good for him. Treatment is aimed at avoiding known allergens and respiratory irritants and controlling symptoms and airway inflammation through medication. So we have Brian on his way to managing his asthma. Now, if you had a patient with a history of asthma in the hospital, we want to make sure that we know what the signs and symptoms of respiratory distress are. So I like this chart. We don't need to go into it because I'm sure you're going to pour yourselves over it eventually. Mild, moderate, and severe, what is going to indicate respiratory distress. We didn't talk about allergy shots for these people. Having gone through allergy shots as a kid, was it effective? Somewhat. I did desensitize to most things. Never fish, never seafood. I have desensitized to grass clippings. Still can't deal with cats. Don't really want to. Probably, I have a dog, but dog dander in a closed house will trigger me. If I'm inside a closed, if it's the middle of winter in Canada and there's no airflow, I will react to things a lot more. I don't if there's airflow. I think that's it. Asthma. Feel comfortable with it? Sucks. It's a bad disease too. Not as bad as diabetes. It's the worst. Take a quick break and then we're going to come back and do our next one. 5 minutes, okay? Can you do it in 5? Oh, I didn't enter. We didn't have, oh, I didn't put that in there. My mistake. Okay. All right, so the ICU nurse calls you to give you a report on Dennis. He's a 56-year-old man with a history of chronic bronchitis. What does that mean he has then? COPD. He quit smoking 12 years ago and exercises regularly. He went to see his physician with complaints of increasing exertional dyspnea. A large mass was found on his right lung. 3 days ago, he went under a right middle lobe and a right lower lobe lobectomy, and the pathology report showed adenocarcinoma. He has no neurologic deficits, and his vital signs are 120/70, heart rate 110, and about 30 respirations. And he has been running a fever of 100.2. Heart tones are clear. All peripheral pulses are palpable. He has an IV of D5 half at 50 mils an hour in his right forearm. He is a right middle lock. Oh, we like the color scheme. Go away. I complain about this every week. Okay, and he has a right mid-axillary chest tube to a pleurovac drain. There's no air leak. It's draining small amounts of serosanguinous fluid. He has complaints of pain at the insertion site, but the site looks good. The dressing's dry and intact. He's on 5 liters of oxygen by nasal cannula. He refuses pain medication. He's a real nervous guy, and he hasn't slept since surgery. He'll be there in 20 minutes. So that's your report. Got on the phone. Get your hand off. You like that hand off? Is it very thorough? What else do you want to know about? Okay, I hear this. O2 sat. Okay, well, so this guy's had 2 lobes of his lung, 5 removed. 2 out of 5 lobes are gone. I kind of would like to know what his respirations sound like. I like a little bit more respiratory report here. It'll just say diminished in the lower lobes. It better say more than that. So, so I want to know what the lung sounds like and what the oximeter reading is. The other thing that we always want, what is one of the first things you say? This patient has no known allergies. Would be significant when you get a new patient to know if they have allergies or not. And their code status. And the other thing I want to know is, how is he tolerating having lost 2 lobes out of his lungs? Is he adjusting? What's the adjustment that's going on? Because it may take a while. And does he have a support system? Does he have any allergies, and does he have family that comes in to see him? So those are other things I'd like to know about. So Dennis is transported by wheelchair past the nurse's station to a room at the far end of the hall, and you enter his room for the first time to find him sitting on the edge of the bed with his left leg in the bed and his right foot on the floor. So he's sort of half in, half out, right? And you introduce yourself. Hi, I'm Sue. I'm going to be your nurse for the rest of the shift. And you notice that he keeps rubbing his left hand over his right chest. Right? Is that what I said? Left hand over the right side of his chest. So he's rubbing. Okay, so these are just observations you're making. What issues or problems can you identify from that? Why is he sort of half sitting in the bed? He's a fall risk. That's a fall risk. There's a safety issue here. What else is going on? Something's going on. He probably has some type of pain. He's rubbing at his chest. Chest pain rub, I always think of cardiac, but I'm going to investigate that anyway. But he's definitely got chest pain. Anybody have an issue with where his room is? Okay, first of all, you get a fresh patient from the ICU. I'm not going to put him way down at the end of the hall. I'm concerned because he's a safety risk. Now that I see him, he's down at the end of the hall and he's a safety risk. So what else do I want to talk about him? What did they tell us about his sleep pattern? He hasn't slept. He's a real nervous guy, and he hasn't slept. So there's some sleep issues. We know if we don't have sleep, we get cuckoo. We do have problems, right? So what are you going to do for Dennis? Find out his O2 sat and his vital signs on arrival. Do a pain assessment and talk to him about the benefits of a pain medication. Good. What else? Check his what? Chest tube. That's good. I'm going to just check it. That's a good assessment to have. Yeah, he's there. Looking at that. Right, right. What else does he need? He needs his call light. And what else does he need in this situation right here? Some side rails would be good too. Yeah, so we want to make sure that the side rails are up. We address this isolation. Probably moving him would be a best idea to do. Or if you can't move your patient and you're concerned about them, you move yourself. And you park outside their room. Or in the doorway. Or next to the bed. Wherever you need to be. And call light. Okay. Dennis states, I have a nephew who rolled his Jeep and busted himself up real bad. He got hooked on those drugs and I don't want any part of them. Okay, how's that going to work? That pain assessment. So how are you going to explain that? You don't get to offer those things if they're not ordered. Uh-huh. Okay, so really what we want to do is we want to talk to him about explaining managing the pain and how you'll have a quicker recovery, there'll be fewer complications, you'll be able to move around, you'll have tolerance for your activities if we can manage this pain. You'll only need this for a short period of time. The short period of time that you will need this pain medication to manage your pain that you have, it's not long enough time for you to develop an addiction. So you can try that with, there's non-pharmacologic methods as well. What are those non-pharmacologic methods? Guided imagery, hot, cold, massage. It's not going to really feel good massaging on your incision. Not so cool. Distraction. Television's great. Television is a great distraction. So why is Dennis experiencing difficulty using his right arm? Oh, we just heard about that. Given the type of surgery he underwent, is this expected? Just a minute. So he had a right mid-lobe and a right lower lobe, and he's having problems moving his right arm. They have to go through all the muscle and they have to go through all those nerves. So it's not uncommon for that to have happen. And so it is expected. There may be transient nerve compression and restricted use of that arm. So if he's freaked out about that, you want to reassure him of that. Any patient that's going to have some lung surgery where they're going in between the ribs, you're going to want to talk to them about there may be some compression initially. It'll work out. I have to sneeze soon. Okay, so you administer morphine 8 milligrams IM and tell Dennis that you'll return in 30 minutes. 15 minutes later, he turns on his call light. 30 minutes is too short, or too long, by the way. It should be 15 minutes. And he says, I think I'm going to throw up. What are the next 3 things you're going to do? Sit him up, get him a bag, check your PRNs, or grab this basin, whatever's in there, okay? Use the bath basin. Those K basins, kidney basins, that is for nothing. That's for brushing your teeth. It's not even good for brushing your teeth. Just grab the bucket. Cool cloth. Question him as to what's going on. And he states, I started feeling sick a couple minutes ago. It just kept getting worse until I knew I was going to throw up. Given this information, what do you think is responsible? What is responsible for this sudden onset? It's the morphine. Yeah. So it is the morphine. And would it be appropriate to give him a second dose? No. So what are you going to do? And what are you going to do when you call the doctor? You're going to ask Bar out off to the doc, right? So you're going to not give him morphine and say, no. So you're not allergic to morphine by barfing. That's not an allergic response. It is a side effect of morphine. So patients will often say, oh, you know, I'm allergic to morphine, it makes me throw up. Well, no, that's a side effect of morphine that you have. So we can give you Zofran with it, and that'll help. probably, it's a discussion between you and the doctor, okay? So is pain and nausea under control? An hour later, and you remove the chest tube dressing and look at the area around the insertion site looks slightly inflamed, and the tissue immediately around the tube looks white and moist, and there's a scant amount of brown drainage. What action would you take? What is that called when it looks like that? Yeah, say it louder. Macerate it. So it's spongy and moist and icky looking. So you could call the doctor and tell them. You can. Who else is at your resources? The wound nurse might have a nice something to say about that. So you'll call Matt because he's going to be the wound nurse eventually. Isn't it you that likes wounds? There's the wound guy. So what can you do without calling these resources? What can you do? Change the dressing. How are you going to clean that up? You're going to throw some peroxide on that? How about some alcohol? Going to throw some alcohol on that? No. Just a little bit of normal saline, clean it up, put a dry dressing on it. So cleanse with sterile water. This says if you still have the tube in place, put the gauze in. What if Dennis, well, this isn't Dennis because I think this is a breast that we're pulling out of there, stands up and stands on his chest tube and it goes, what? What are you going to do? Three. Will it be a sucking chest wound? I don't know. If it's a sucking wound, then you have to just tape it on 3 sides so you can exhale and the air can go out. But when you inhale, the flap comes back down, right? So you're not sucking back in so that you don't increase your pneumothorax. That's if you have a sucking wound. Hopefully it won't be because you're going to react so quickly that tube's going to come out and you're just going to pop something on there right away, right? A dry dressing, probably petrolatum. Yes, whatever they said in that movie. Put on a Vaseline gauze, seal it up. Whatever you have on hand is what you're going to put on there initially, right? That would be if they accidentally pulled it out, or if you were standing on it and it pulled out because you did that. That would be bad too. Okay. So the next day, the nurse is giving you a report and says that Dennis has been driving her crazy all day long. And she tells you that he is fine, but he's been paranoid and demanding. And you enter the room and you see how he's doing. And you tell him you're going to be his nurse again today. And you notice head bobs up and he's sitting there like this. Dad. What's going on? He's doing the fish out of water, right? What's going on? He's in respiratory distress, correct? All right. So possible reasons for respiratory distress. What do we think with this guy? What could have caused that? What's that? Hemothorax. He's bleeding internally. Okay, hemothorax. What else? Pneumothorax. He's having problems breathing. He has a history of chronic bronchitis. What do chronic bronchitis people make? Mucus makers. There could be a mucus plug. Maybe he has a mucus plug. Maybe he's having an exacerbation of his chronic bronchitis. If he has an exacerbation of his chronic bronchitis, what are we going to see? Fish out of water, could not be breathing. He's having trouble breathing. Maybe it's that. What else is going to make individuals react that way? What are we going to see respiratory distress from? What else? Pneumonia could do it. Pneumothorax, we talked about that. What about pulmonary edema? Did we talk about that? What about adult respiratory distress syndrome? Could have progressed to that. What about a pulmonary embolism? Do they look like this when they throw an embolism? Yeah, they do. So there's all sorts of possible problems. So what should we do next? His respiratory rate is 46 breaths per minute. You auscultate a slight air movement over large airways. No breath sounds the distal third of his intercostal to the distal third intercostal space. 1, 2, 3. Okay. Here. Nothing from here down. He's sitting on the side of the bed with his arms hunched up on the overbed table. His gown is in his lap. He's diaphoretic. You note intercostal retractions with inspiration. All muscles of the upper torso are engaged in respiration. What are you doing now? Okay, is this a rapid response situation or is this a code situation? We're at a code. Look at this. This is code status. This is a respiratory arrest just about to happen. This guy needs to be intubated real quick. We waste time calling rapid response for that. Just call a code. Okay, so we're gonna call the code. What do you do next? Call the code. Whatever facility you're in, make sure you understand how to call a code in that facility. Some hospitals have a code button at the head of the bed on the wall. You ever seen those? Those are not to cancel the call light. I've done that. I called a code on my mother. Trying to cancel the call light. Yep. In a hospital I used to work in even. Stupid. I had to apologize to like people I knew. I was tired. I was calling. Yeah, I was called home. Yes, stress. It was embarrassing. Okay, so we call a code. Code happens. All right. Press the button like that. That's not to cancel the call light. He's successfully resuscitated and transferred to ICU. The physician returns to your floor and compliments you on your clear thinking and fast action. They do that. They do come back and talk to you. Sometimes they do. I still remember Dr. Conley for coming back and talking to me. So the nurse who gave you a report comes up to you to apologize, and she's relatively new and asks you to explain how you know when a patient is in the early or late stages of respiratory difficulty. She states she wants to learn from her mistakes so she doesn't put another patient through what Dennis experienced. So by the time you came on to your shift, you had to call a code. That just didn't happen in a second, right? He spent all night getting to that point. He was increasingly anxious. The less oxygen that gets to your brain, the more anxious you get, the more confused you get. So how do you distinguish between early and late? So let's start with early. We noticed an increased sign of respiratory rate, decreased tidal volume, increased use of accessory muscles. So they're starting to use other muscles. They get a little breathless while talking. Before they were able to do 2, 3, 4 sentences when they talk to you in a breath. Now they can't. They have to catch their breath in between sentences. That's the crows. Here's the crows talking to you. Their heart rate goes up. Another crow. Pulseless paradoxus. What is that? Somebody tell me. So the intensity of the pulse changes with respiration. You can feel it with their respiratory rate. They become agitated, they're restless, they're moving around in bed. They need to get up, they need to get down, they need to sit on the side. Now I need to sit in my chair, I need to go to the bathroom. That kind of thing, they're restless.
You said you can feel the pulses changing, the intensity, but are you doing that on a blood pressure cuff? What's the millimeters?
It'll jump when you're doing the blood pressure with their respiration. And you can actually feel it. But to get a true pulsus paradoxus, you have to put the blood pressure cuff on. You're not going to do it. Really? You're going to look at all these other things. They have lost their sense of humor. It's not funny anymore. They were joking and having a good time with you, and it's not good anymore. And they're very focused on their breathing. They don't want to talk about anything else. They would really like the fan in their face. You notice all the hospital rooms that have a fan? Those are for the COPD patients. Because just the act of the air moving towards their face, there is a belief that they're getting more oxygen. Studies have shown there's no difference, but it is psychologically advantageous to have that fan there. COPD patients in end stages have very little control over their lives, so they extend their control as often by controlling those around them. So I can control the nurses a little bit, and I'm much more demanding. Patients who are lungers are a little bit more demanding. They like things to be specific for themselves. I want this fan to be angled at 70 degrees right here. Like, there is very little control they have over themselves, so they're going to control everything else. You just got to roll with it. Sometimes the third day with that patient, maybe you need to be moved to a different patient because your patience is gone, but they need that. That's part of what they need. Okay, so those are early signs. Later signs, they're over 30 a minute. Breath sounds are decreased, they're absent. With asthmatics, we like to hear wheezing because we know air is going through there. When they stop wheezing, those airways have tightened, and we have a status asthmaticus, and that's life-threatening. So we want to hear air going through airways. We're going to see them using all the accessory muscles. Maybe they're posturing, maybe they're not even talk. They can't talk now. There's no talking. They can't lay down. There's gas changes. They may be somnolent because they're not getting enough air to their head. You're going to see that belly breathing, that paradoximal demonstration I gave you before. And their skin will be cold and clammy. Late signs of respiratory failure. They will likely be acidotic. Their pH will be low. Did Dennis leave happily ever after? Well, let's find out. Dennis has a long history of chronic bronchitis and has undergone right mid-lobe and left lower lobectomies. 2 of the 5 lobes have been returned. His tidal volume has drastically reduced and will take approximately 6 months for the remaining lung tissue to hyperinflate. So it's not like he's going to have a void here forever. These other lobes in his lungs are going to increase in size and take over that space. But he's still going to have reduced alveolar surface. He's never going to gain back the alveolar surface to pass oxygen. So any compromise to his respiratory system will have an exaggerated effect on him. This is a guy that needs to have the flu shot. This is a guy that needs to have the pneumovax. This is a guy that doesn't go around any snotty kids, ever. He's respiratory compromised for his entire life. All right. Any questions? Oh, Heather, you want to tell them what I have to do now?
So she's gonna read the test.
Who's going to read you the test? The one that you get next week makes me look really bad. No. Shall I record it or shall I turn it off while I record? Okay, a nurse assesses a client with this specific disease. Which assessment findings should alert the nurse to immediately contact the healthcare provider? A nurse cares for a middle-aged client with something, and then she has her third episode of this acute thing in the past year, and asks, how can I prevent this? And the nurse responds by saying, the nurse evaluates a client with a specific kidney disease. And which manifestation should the nurse recognize as a positive response to the prescribed treatment? After teaching a client with a kidney situation, the nurse assesses the client's understanding. Which statement made by the client indicates correct understanding of the nutritional therapy for this condition? Is this helpful? Which statement by the client indicates need for further teaching? A nurse assesses a client with this particular syndrome, and for which clinical manifestations should the nurse assess? And here's a lab value, and how does the nurse interpret this finding? And we're assessing a client with a diagnosis of a kidney thing. Which condition would the nurse expect to find in the client's history? So that would be what people are predisposed to, right? More labs. What questions should the nurse ask first when taking the client's history? Taking certain medication for management of this chronic disease. How do you know it's effective? What is the ideal goal of treatment set by the nurse in the care plan to reduce the risk of this certain thing? Teaching a patient with a kidney issue about a restriction. What statement indicates that they need more teaching? What assessment finding would alert the nurse that something's never mind. Okay, the patient is having a treatment. What is the priority action of the nurse when you see this? Which statement by the client demonstrates correct understanding of the teaching? Nurse is caring for 5 clients on the med surg. Who are you going to see first? What are the advantages versus the disadvantages? What is the advantage? Never mind. Compare and contrast 2 things. In your mind, compare and contrast 2 treatments for kidney failure. And there's a picture. They were lungs? Heather said they were lungs. Acidosis, alkalosis, acidosis, alkalosis. There you go. Okay, ABG, ABG. Caring for a patient who had a diagnostic test. What do you do afterwards? Assess a client using a device pictured below. There you go. Visiting a new client who uses home oxygen. Something about oxygen, I guess. Teaching. Nurse cares for a client with this. Oh, I actually even talked about that today. You guys already know that. After teaching who has been prescribed something, the nurse assesses the client's understanding. What statement indicates they comprehend? Which diet selection should the nurse provide for the client? Which action should the nurse take first after looking at this issue? I talked about that today too. Which action should be taken first after doing something? I can't tell you that one. That's too giveaway. That's a giveaway. Which client should the nurse assess first? Do you want me to continue? You like this? Is it helping? Nurse administers medication to a client who has a disease that we studied. And which classification is correctly with its physiological response? There you go, to the medication. That's actually a good question. Which medication classification is paired correctly with its physiologic response to the medication? ABGs. What action should the nurse take first after assessing and finding these crows? Which action should the nurse take first? Which statement related to nutrition should the nurse include in the patient's teaching? Lots and lots of nutrition. Is that what you just said? I said it twice. I'm trying to say this stuff so that you guys don't get hung up on things. I've said ABGs probably 3 times. 3 times. Maybe only 3 questions, Heather. The point I'm trying to make is do not spend all your time studying on something that might only have 1 or 2 questions on it. Think about big globally taking care of respiratory patients, globally taking care of kidney patients, right? I'm lost. Oh, that's a nutritional one. Which of the following medications would be indicative of something? Oh, here's a calculation. There's 2 calculations. I think I wrote, you guys got all that breakdown yesterday, correct? All right, see? Your nurse is caring for a client who has sleep apnea. And it's prescribed a medication. A nurse has several clients who have a history of asthma. Who do you see first? And then they tell you a bunch of different ones, right? So we got 4 asthmatics. Which one needs your attention first? Things that you teach them. Psychosocial. Statement indicates client correctly understands the teaching. Client tests positive for AAT. Okay. I didn't talk about it, but now you're going to research it. I did talk about it in the online lecture. Which questions should the nurse ask to determine something? Which intervention should the nurse include in the plan of care because of these crows that you've found? because of the crows that you found. And then there is a essay question for 5 points.
Renal or
Respiratory.
respiratory?
One of my favorite topics. Any questions, concerns, comments, criticisms? I'm expecting you guys to ace this exam. I want you to review COPD again. I want you to think about what we globally do for respiratory patients, and renal for that matter. So next week we'll have our test, like we always do, in the library at 8 o'clock. And I think that's it. Good? All right. You're welcome.